You're listening to The Scoop on Ultrasound, where the world of ultrasound imaging comes alive through dynamic conversations. This episode is brought to you by EDM Medical Solutions. Be sure to follow the podcast on your favorite app so that you never miss an episode. With us on the show is Dr. Wendaline VanBuren, a radiologist whose work is redefining gynecologic imaging. She's an associate professor of radiology at the Mayo Clinic, specializing in ultrasound, abdominal, pelvic, and breast imaging. Dr. VanBuren chairs the gynecological imaging section at Mayo and co-founded the Endometriosis Disease Focus Panel for the Society of Abdominal Radiology. She's also the founder of the International Endometriosis Imaging Congress, a global platform advancing collaboration and education in endometriosis care. In this episode, we explore how innovation and advocacy are transforming the way we image, understand, and support patients with endometriosis.
Quality supplies make a difference. At EDM Medical Solutions, we support over 2,000 healthcare facilities across the U.S. with high-quality medical products built for real clinical needs. From ultrasound imaging accessories to surgical instruments and everyday disposables, our portfolio spans women's health, men's health, and the operating room. We've spent over 35 years helping practices deliver safe, efficient, and cost-effective patient care, with the personal support only a family-owned company can provide. Explore our full range of solutions today at us.edm-imaging.com.
Today's episode of The Scoop on Ultrasound is for anyone who's been watching the rise of advanced gynecological imaging and wondering where it's headed next. Our guest is someone at the forefront of that movement. Dr. Wendaline VanBuren is an associate professor of radiology and a board-certified radiologist at the Mayo Clinic with subspecialties in ultrasound, abdominal pelvic imaging, and breast imaging. She currently chairs the gynecological imaging section at Mayo Clinic's Division of Abdominal Radiology and is the co-founder of the Endometriosis Disease Focus Panel for the Society of Abdominal Radiology. Dr. VanBuren is also the founder of the International Endometriosis Imaging Conference, which is going into its second meeting this year. She is widely recognized for her leadership in endometriosis imaging, advancing everything from protocol development and scan interpretation to education and international collaboration. Her work integrates ultrasound, MRI, AI, and nuclear medicine tracers to uncover new pathways in diagnosing and managing endometriosis. Most recently, she served as senior author on the Society of Radiologists in Ultrasound Consensus on Endometriosis, published in Radiology in 2024. Dr. VanBuren, welcome, and thank you for joining me on The Scoop on Ultrasound.
Thank you so much for having me. I appreciate that.
So let's start with the moment where this all became more than a clinical interest for you, Dr. VanBuren. We know endometriosis is notoriously underdiagnosed, but imaging, when used early and interpreted with skill, can offer life-changing clarity to these patients. Was there a moment in your career when you realized imaging could completely change the conversation around endometriosis?
Absolutely. Thank you for that question because, when I first started doing endometriosis imaging, I was a fellow and there were no society guidelines that recommended imaging for endometriosis. So over the last 11 years, we've come a really long way in terms of societies making these recommendations and radiologists learning, and sonographers and gynecologists as well, to use endometriosis imaging for the diagnosis of endometriosis. And part of that is understanding the strengths and limitations that we have. So yes, you make a great point. With ultrasound education, it is very operator dependent, as we know. So it's important to have the appropriate protocols, the reporting, the expertise, and the education to carry out that mission.
Yeah, for sure. And education is a really important part in that, isn't it? That's why we need to have those updated protocols. Despite this potential, the average time to diagnosis is still far too long, and so many patients struggling with these symptoms, right? And with endometriosis, once they get the diagnosis, feel that way, right? That it took so long to get there. Why do you think it still takes so long for many women to get diagnosed, even with advanced imaging tools available?
Sure. Well, there's a couple of aspects to that question. It's not as easy. So we could address that from a couple of standpoints. So we could take a look at education regarding endometriosis from patients and their symptoms, but also too to their referring providers and understanding the multitude of presentations that can occur with an endometriosis patient. Then we can take a look at the imaging specific variables, which are the ones that pertain to the scanning, the protocols, and the interpretation. And then looking at the sensitivities and specificities. So it's like a lot to unpack, right? So let's start with, you know, A through Z, a little bit of this. So the patient presentation is it can be a variable, right? We know we're dealing with something that's very prevalent and that it's typically speaking a chronic disease. So we have somewhere between 1 in 7 and 1 in 10 women impacted by endometriosis. They may present very differently, and disease severity is not necessarily linked to the symptoms. So pain symptoms can occur, but also nonspecific symptoms like bloating. It is the leading cause of infertility as well, and some of those patients may actually be asymptomatic, particularly if they're on hormonal IUDs or OCPs. So you kind of have the spectrum between asymptomatic, but perhaps presenting at time of infertility, all the way up to severely symptomatic, and then specific cohorts within that too that are even more complex. So those that might have endometriosis associated cancers. So this is our very heterogeneous background patient population. And then you look at all the different environments that these patients may interact with. So likely their family doctor, or some type of primary care physician, possibly a gynecologist if they get there, but probably not a subspecialist in endometriosis yet. Maybe a gastroenterologist, maybe a urologist, maybe a pelvic floor specialist, maybe fertility expert. So you have a large group of physicians who need to become aware of endometriosis, how common it is, and how vastly variable the presentation is. Right. So that's sort of, barrier number one. But also, too, it helps if patients understand that there are a variety of symptoms and presentations and environments that they could also fall into in terms of that consideration. So that is, one of the barriers. Another barrier, of course, as we, embark on something that is relatively new with regards to imaging and to medical integration is, of course, societal acknowledgement of this disease, which is not a new disease, right? It's been as long as we have probably, but whenever we're trying to gain, some acknowledgement for new advances and clinical recognition, there's a lot of legwork involved with trying to change thought paradigms within medicine and thought paradigms within society. And so those are two additional barriers. So then we take a look at to the actual clinical implementation. There are barriers to onboarding something new in our practices, right? Because no one has historically been educated in this domain. So you don't necessarily have a uniform offering with standardization that's available to either referring clinicians or patients for them to know that they're actually receiving the standard or the highest standard that we have available. So that uniformity is lacking. And then we have a problem even with understanding what the technical uniformity could be, the education to carry out, those technical aspects, and then finally the reporting of them. So we have a lot of barriers on many levels. I prefer to refer to those as challenges because when you talk about something as a barrier, it makes it seem like it could be something that is insurmountable or difficult. When I think you pose it as something that is a challenge, it's something that you feel empowered to do something about. And that we really can leverage all of these challenges in different ways together and, with various tools to really kind of like make impacts and difference. And not all of those barriers or challenges are going to be stagnant or move together. So they kind of move independently from one another, but often synergistically.
You make a great point when you talk about the barriers or the challenges, right, at the societal level and within medicine when it comes to awareness about the disease. For so long, it's a disease that has been dismissed, right? Even within the medical community has historically, right, at times dismissed it. Of course, this is changing, right? Because as our understanding increases, we expect, right, that the awareness will also increase. That being said, do you still think that in the medical community, there's a delay even among some practitioners, perhaps, who haven't really caught up with the times, as they say? The research just hasn't really gotten out there? Or do you feel like we finally gotten to a point, that critical mass, where, yes, the majority of the medical community is on board and there's a pathway to actually acknowledging the disease when the patient comes in with these symptoms?
I would like to say that I think everyone has onboarded and we're uniform in that understanding, but I think we still have some steps to go. However, there has been increasing momentum over the last few years. I think some higher visibility journals and increasing groups of individuals carrying out the work and more presentations and educational opportunities, different countries approaching it in different ways with differing levels of priority, I think has really highlighted the disease and allowed us to do the advocacy work that is necessary for increasing that uniform understanding. But we are still, I would say at early stages for onboarding societal understanding in the United States in particular. I think there's still a lot of heterogeneous understanding. I think even, myself, as I speak to audiences of gynecologists, that may be very variable based on what their personal experience has been with imaging. And oftentimes that may be dictated based on historical context. Even radiologists, it may be the same way. If they haven't seen cases, if they haven't been shown exactly the impact that can occur with the power of diagnosis that we have, I think that they may have preconceived notions about limitations. And it's not until they see the cases, that they see the patient impact, that they start to realize, like, wow, times are changing. So it requires this growth mindset always when we're going to try to make, paradigm shifts in people's established thought patterns. So everyone has their own stage of readiness with regards to that. And eventually we will reach a certain, mass number of individuals. And then it's going to become socially unacceptable to not believe anymore that this is the path forward. And we are slowly getting there. And I think that there is growing momentum and acknowledgement for that.
That's great. That's great. Awareness is key, right? Awareness is key, especially for issues such as this, where you're trying to do, like you said, a paradigm shift. Now, you've helped pioneer protocols and technologies, right, that go beyond traditional pelvic imaging. Which recent imaging breakthroughs aren't just technically impressive, in your opinion, but they truly do change the lives of women with endometriosis or suffering from those symptoms?
Yes. Well, and that's the thing. We've had improvements in technology over the years, which allow us to see, with higher resolution, smaller deposits, because endometriosis itself is a disease that has highly variable presentations in terms of the size of lesions and how it looks. But I'm not going to address that question right now. I'll answer your question actually, which is about the advancements. So one of them is the Society of Radiologists and Ultrasound consensus on endometriosis imaging that was published in the Journal of Radiology. And that actually stems from our clinical experience. So most of the research things and advancements come from living in the clinical space, seeing the cases, and knowing the types of instances where we can really make improvements. And generally speaking, improvements come from areas of frustration where you see a need for improvement. If we were already at the pinnacle of our functioning and the maximum capacity for our abilities, that wouldn't be necessary, but we're not there yet. So the question exists. You have a huge patient population impacted by endometriosis, and you have, generally speaking, routine pelvic ultrasound, which are doing a suboptimal job of identifying those patients. But what do we see when those patients eventually come to MRI or advanced imaging on their early ultrasounds? Well, you can have adhesions in the pelvis. So simple maneuvers like a sliding sign or evaluation of the posterior cul-de-sac, where we know is mainly endometriosis is a disease that impacts outside the uterus and ovaries on the surface. So if you're going to really just focus on the organs, you're going to miss most of the deep disease. So taking a look at that posterior cul-de-sac space in a more concerted way and really including many attributes, including patient symptoms, which allow us to then empower radiologists or those who are performing scans and interpreting them to then triage the patients to advanced imaging or advanced gynecologist or care providers for endometriosis. So what we really want to do is introduce something that is accessible and easy to be taught, and also empowers people to help patients on their diagnostic pathway forward. Because I think the issue in the past was that we would have patients that would receive a normal ultrasound report, they were still symptomatic, and then they were dismissed in terms of their evaluation of their ongoing care. So, I think the most powerful thing about the SRU consensus is that it does allow patients to continue on their diagnostic journey, to not be, neglected in terms of the symptoms that they're having and their pursuit of the diagnosis. So, that's something that doesn't involve any inventions. There is no like new technology that was developed. It is a reorganization of our observations using techniques in a slightly different manner, compiling the data and putting them forward in recommendations. So that comes from, over a decade of experience with the ultrasound patients and knowing exactly who should fall on that pathway. And as time goes on, we'll see more and more validation of these efforts.
That's great. I mean, it goes to show the importance of that work together as a group, right? It's why these efforts sometimes are so global, that they bring together so many voices, right? And so many experts on it, because it really does take a group to do it. And it takes time, right? It does take time as we go learning over the years, case by case, but just so great to see that all come together. Now, in 2023, you founded the International Endometriosis Imaging Congress. But this really isn't just a conference, right? It feels like a movement. How do you see the International Endometriosis Imaging Congress as more than a scientific event? What kind of change are you hoping to spark?
So thank you for asking that because it's something that, of course, I feel very passionate about. It is, when we take a look at this disease and the WHO, if you look up endometriosis, has acknowledged it as a global problem. So this is not just about putting together a radiology meeting to learn about how to image endometriosis, although that is a big part of it. What it is meant to do is to take a look at the disease across the world and our diagnostic delay and how that impacts women, knowing that we all have very different socioeconomic and cultural considerations from a patient standpoint, but also from the standpoint of medicine. And how do we bring ourselves together to collaborate in a way that can amplify our efforts to share what we're doing in our respective practices and countries to assist each other with the status of this? Because a lot of times people do think of it as a disease that impacts women, but it really impacts society when we're taking a look at really important things like family planning and education, career, social engagement. These are all things that are part of the fabric of our cultures. And so, how do we maximize that going forward? And oftentimes, I think it's those relationships that we build with one another, where we're able to do more for research, more for clinical work, and see our impact go even further. Because for me, I felt a little bit frustrated. I felt like I was academically siloed in some ways, and wanted to see that outreach go on a broader level, so that we could see more uniform changes and more engagement, within community medicine in the United States, but then also on a larger scale globally.
This leads right into my next question. The fact that endometriosis research is often far too underfunded and underprioritized. In 2022, actually, the NIH's expected funding allocation for endometriosis was 16 million, and that's just 0.038% of the budget. And given the conservative estimate of 11% of US women affected by endometriosis, that would actually represent only $2 per patient allocated towards research. And that's tiny when you compare it to other diseases, for example, such as research for women with diabetes. With the funds allocated, it would come out to about $31.30 per patient. So just such a disparity there. Of course, clinicians like yourself are pushing for endometriosis to be higher on the agenda. How do you balance the science, right? What the need to advocate for equity in women's health, and how can radiologists themselves use their platform to amplify patient voices?
So when I started off in medicine, I never imagined I would be in an advocacy role. It's especially in radiology because you think of yourself a little bit more siloed, but it's because of the lack of acknowledgement and recognition for the disease and for the patients that after a while it really starts to wear on your heart and soul and it makes you want to do more. And so it's things like the SRU consensus, but also government advocacy work. And, I realize that the funding is very low. And most people don't realize it is as common a disease as diabetes type 2 for women. But even in medical school, how often were people taught about endometriosis? I mean, I was taught about diabetes probably 11 independent times. There's no way I could have graduated medical school without having seen diabetes back, forward, sideways, every which way. And endometriosis, I would say, I don't even know if I had a dedicated hour of teaching. So it just goes to show the educational discrepancy. And then that has historic roots. So the NIH funding issue is a result of some of these very, entrenched disease recognition tendencies. So I think as we start, diagnosing and learning more, it is up to us as radiologists. We are kind of like in the quarterback position here where we can see the disease, its manifestations, all of the ramifications for these patients, whether they be fertility or cancer or chronic pelvic pain, the tremendous surgeries that are involved. I think that we really are at the forefront of being able to advocate for it because someone needs to sound the alarm bell and say, look, this is out of control compared to other diseases that I see that are managed much more effectively early on before they have these dire consequences. So the research funding, it certainly does need to improve. I think that as people start to recognize that we actually have a growing, some of it is going to be related to the diagnosis that we have an increasing number, but there's a lot of uh, you know, endocrine disruptors in our environment now, and those things are also feeding into endometriosis and perhaps the increasing prevalence of that. So we know that we have a birth rate issue that's low globally. Fertility is a concern for us as a planet, and we need to figure out like how to optimize fertility. And endometriosis, I think, is going to be one of those game changer diseases that I hope we recognize in this categorization sooner rather than later, because it will be to our advantage as a society to preemptively diagnose and help facilitate certainly, at least one component of the disease, which is that one that's fertility related. But there are so many reasons to increase the funding. If you look at endometriosis associated malignancies, really it's a benign disease. Um, so if we're able to, have research that can identify who is going to go on to have malignancy, maybe there's a whole cohort of cancers that we could completely uh, prevent. So imagine that if we could take some types of ovarian cancer and ensure that they never occur. How amazing would that be? You don't need to invent a new drug or molecular marker or anything like that. You just have to figure out who is going to progress, and in doing so, prevent cancers. I mean, that's amazing. So I think there's so much potential for the research. I think that we have a lot of avenues where the funding could be allocated that would make tremendous societal impact. And I think it's just going to take time as our clinical practice and research evolves for others such as the NIH to see that.
If you are high-level disinfecting your ultrasound transducer, it's likely you're soaking the probe or using an automated HLD device. But there's a better option out there. TriStel Old can high-level disinfect your transducer in just 2 minutes and costs under $3 per cycle. Sound too good to be true? Request a brochure today and learn why so many practices are switching over to TriStel Old. Visit us.edm-imaging.com/TriStel. That's TRISTEL. And now, back to the show. It truly does have such important public health implications, doesn't it? It's really almost like a public health emergency. It's just it's not perceived that way, I think, by the general public, right? Or even the medical community at times at large, like you're saying, there's a increase in awareness. But it's taking time. It's taking some time for the research to also catch up. So it really is so important to see clinicians such as yourself, of course, highlighting that, right? Especially with the Congress, which you founded to put the spotlight on the disease because it is common. It's more common than perhaps some people think. Now, let's imagine a better future because this is what it's all about, right? If a young woman walks into a clinic 10 years from now with symptoms of endometriosis, what do you hope her journey will look like?
So, I do have a particular vision for this, and that is a little bit, why the Congress was founded, because I also work in breast imaging and I see a lot of similarities with respect to the diseases in terms of the way they could be managed. So we know that endometriosis has a very high prevalence and it's generally speaking a chronic disease. So we have to be able to manage a woman over the course of her lifetime, not just one moment in time. And there has to be a way to facilitate not just expert level diagnostic work, but also to population based evaluation, which we have to take a look at our workforce and our resources. So there's many different tiers of application for this. So I think the ideal environment would ultimately be something like a breast center, but for endometriosis imaging. So imagine our communities all have endometriosis imaging centers that start with something like a pelvic ultrasound that is, a reasonable cost. The access is good. We can train sonographers. They'll be improving diagnostic tools available going forward. So whether that's AI assisted, I think that's going to really help improve both the learning and detection and reporting. And then going from that sort of, if you will, screening environment, which hopefully it gets to that someday, that we can then identify those individuals who need to go on to more advanced diagnostic exams that are more cost, labor, and skill intensive. So whether those are bioprepped expert level ultrasounds or dedicated MRIs. And then, taking a look at things that might be forthcoming. So are we going to have like nuclear medicine tracers? In Europe, they have the CE mark now for HIFU, high frequency ultrasound bowel treatment. What are all the different interventional or minimally invasive therapies that we can use that could be carried out for patients to bridge them through some of these areas in life where we know we want to have successful pregnancies if they're looking at family planning. Also, too, if they're going to not have a surgical resection, which a lot of our patients, about half of our patients at Mayo Clinic, opt for medical management. So we need to continue to monitor those patients. So we have to be sure that we're capturing in an appropriate manner that there's not increasing severity of disease, that they are responding appropriately, that they're not having their ureters obstructed in a silent hydronephrosis that leads to loss of kidney function, that they are not progressing onto malignancy. So it's well established with the ovaries, but we know that recent articles have showed us that deep disease plus ovarian endometriomas, it was published in JAMA, has an even higher risk of malignancy. So can we extract certain cohorts of patients and then be sure that we follow them to make sure that we're treating them appropriately? So we need to really, I think, organize ourselves. So I hope that that young girl, when she walks into the office, is acknowledged right away for her symptoms that she's having. Or if she's screening, just knows like this is the age I should be evaluated to be sure that everything will be fine with my family planning going forward. I don't have to have any stresses in that regard. And then we'll know that they are in a trusted environment where they're having the appropriate exam so that they can have a trusted response from that exam, that their care provider understands, hey, this is like this step in this person's life to be evaluated for it. And all the subsequent steps that come forward would include referral pathways that would then be appropriate. Say there was the need for fertility treatment. So say, for example, we don't know, who or why some patients have more severe disease when they present. But say you were 22 years old, you walk in the door and you have severe advanced stage endometriosis. I've seen these cases. So of lots of others that work in this space. But you're not ready to have a family yet. And you don't want to feel, feelings of desperation around that. That perhaps would be a good time to start having conversations about what could be used to facilitate fertility purposes. So just using like isolated examples like that, we could come up with really a standardized workflow of recommendations for our patients. And then take away, a lot of the feelings of, medical gaslighting where people feel unheard, they feel unacknowledged. We have just, heterogeneous understanding of the disease, of the management, misinformation, mistrust, so that all of these layers could be, I think, taken care of by having this uniformity within an endometriosis imaging center of excellence model. And so I think that that is something that could look different, perhaps for every country. In terms of what they do, some countries physicians perform the ultrasounds, and others, like the United States, become sonographers. MRI access may be different depending on what country you're going to. So I'm involved with work in both India and Africa and taking a look at our resources there and who has access to medical imaging, what modalities, what expertise. It can be variable, but we certainly are looking at the same disease process that it presents very similarly, and we can take a look at targeting what is the best circumstance for evaluation in those contexts. So that's my personal vision. I think that would be the end of my career. Hopefully, we'll see something like that established. Would be just fantastic. But I certainly think that we have a lot of work to do before then, and fundamentally, I think it starts with education and discussions like this, where people really start to understand a little more how they can contribute, what they can learn, how they can help change their practice and the experience for patients that they're encountering.
I love how you paint a picture really where the patient is at the center, right? There's so much talk about patient centered care, yet more often than not, sometimes the patient isn't really at the center anymore. Obviously, healthcare is very complex, right? There's a lot of factors, but some clinicians who have been guests on the show have pointed out to the fact that sometimes we can even forget about the patient, with all the things that we're trying to do. So it's really great to hear how the model which you are advocating for in the future, which is for sure where we're heading, right, is going to be so patient centric in that regard because so often, like you mentioned, so many patients have talked about feeling like they were gaslighted along the way, right? They weren't heard, they didn't feel heard. Obviously, awareness plays into that, research plays into that. We are advancing, and those advancements are having an impact, right? So it's a multi factor situation, but just so great to see the picture which you paint. Now, many of our listeners are clinicians themselves, of course. They're sonographers, they're OBGYNs and radiologists such as yourselves, and they want to do better for their patients. But sometimes it's easy to feel like you're not sure where to begin, right? Especially perhaps if this is not the main topic of interest for them or just an area where they really studied too much on, but they want to help patients. So, what advice do you have to clinicians who want to build more confidence in endometriosis imaging and they want to become part of the solution? What's that key piece of advice you would give them?
I think that interdisciplinary collaboration is really key. So to try to do something alone is very difficult. I think that to find a clinical partner is the ideal circumstance. So if you're a gynecologist, find a radiologist. If you're a radiologist, find a gynecologist. If you're a sonographer, find both. Uh, or certainly a radiologist partner. And that's kind of key is to finding that team of people to work together, and having even it doesn't have to be frequent communication, but having this open dialogue, understanding the patients more and more will help to refine the practice environment. And until there is like this uniform education at mass level where we pass down to all of the people that we're teaching in our own respective specialties, there has to be a little bit of that where you're kind of like forging that new territory, right? And so that clinical practice environment is new. It's exciting. It comes with pros and cons too. So you get to be a trailblazer in this environment. You get to offer new things for patients, but we also requires a lot of patience and tolerance, one for the other as well. So as gynecologists learn what radiologists are capable of doing, as there's always a learning curve from both sides of the equation, actually. So I see sometimes we have expectations of perfection early on because that's how we're trained, and literally everything else that we do in medicine is to achieve perfection. But when you're learning new things, you have to have a certain amount of patience and tolerance. And so I think that's part of it. Accessing papers. We have a state of the art imaging paper in the Journal of Radiology. So that came out in 2024 as well. And it goes over some of the sonographic findings you can see as manifestations that would present as part of the SRU consensus, as well as MR interpretation guidelines. So that includes like an expert survey of MRI readers for endometriosis. So knowing where to put that sensitivity and specificity. And there'll be some, videos and examples in those two papers that I think are helpful. And then things like the Congress. So there's not, like unlike SBI, Society of Breast Imaging, who has their own meeting, there was really nothing for endometriosis. So of course, I love going to speak at any meeting possible to describe what we're doing, but it does oftentimes involve a little bit more time and exposure because the disease is very complex, to understand the spectrum of ultrasound through MR and that relationship that we have, with gynecology, whether it's, an excision surgeon or whether it is a fertility doctor or chronic pelvic pain specialist. There's a lot of learning to be had. So I think that, even taking a look at my Congress, it's two different tracks. So one for sonographers or those who are kind of new to endometriosis imaging and those who are more advanced. And last year's program compared to this year's program, there's a lot of new information. So, you know, ideally I could make this a week long. There is a lot of information there. It is not just diagnosing endometriomas. But taking it sort of one step at a time for people, I think is really important. Otherwise, it can feel a bit overwhelming. So, understanding sort of some fundamental skills and building on it, it's very exciting. I see that even in our own practice, working with our sonographers who are doing higher level exams, the learning curve would exist, the excitement when being able to make a diagnosis for someone when they've previously been suffering, sometimes for decades before they have made their way, is really impactful. It's sad. It's atrocious that is the circumstance, but at the same time, it is something that is a constant motivator in your practice for change, to reinforce the hard work that you're doing, because it is worth it. You will start to see that pay dividends when you put in the effort and you start to see the improved patient outcomes from that.
Absolutely, absolutely. Collaboration is key. And Dr. VanBuren, if our audience wants to learn more about the details for the International Endometriosis Imaging Congress, where could they find that?
Sure. Well, we have a website. The website for the International Endometriosis Imaging Congress is eice.ltd, which is Endometriosis Imaging Centers of Excellence.
Excellent. Well, thank you so much once again, Dr. Van Buren. Your work is truly helping shape the future of what it looks like to diagnose and then treat endometriosis. And your passion definitely came through with all the insights that you shared. I'm sure they're so valuable to our audience. So it was an honor to have you on the Scoop on Ultrasound. Thank you.
Thank you very much. I appreciate that.
Thank you for listening to this episode of The Scoop on Ultrasound. Subscribe today to be notified when new episodes are released, and visit our website, us.edm-imaging.com, to learn more about who we are and what we do.